Dr. Arvind is a good friend and he is the chief of head and neck and thoracic oncology at Adyar Cancer Institute and is trained from Tata Memorial. Arvind?
Yes, sir. Yes, sir. I'm sharing my slides now.
How was the scene in your institute as far as COVID is concerned?
Okay, sir. I think in between we had some sort of a scare. We had some few sort of cases a couple of weeks back. So I think after that, I think now we are sort of slowly settling down.
Settling down. You restarted your elective surgery?
Yes, sir. Yes, sir. We did start that.
Okay.
Yeah. I think the outset, I'd like to thank Dr.Patta, Radhakrishnan sir, for the opportunity. I bring greetings from three wonderful institutions that actually shaped me. The very own Madras Medical College in Chennai, then the Tata Memorial Center in Mumbai, which actually made what I am today. And now I've been practicing at the Cancer Institute Adyar as a professor for the last 4 years.
Your voice is not still loud enough.
Okay.
Can you go to use the computer audio?
Okay. Is it better now? I think.
Yeah, somewhat, yes.
Yeah. Okay, sir. I'll probably talk a little louder. Yeah. You interrupt me if the audio is not that clear.
Sure.
Yeah, sure. See, the broad treatment schema for this talk is to just have a glimpse of the epidemiology, etiology, and very quickly go to the meat of the discussion. That's the evaluation and the management. And also touch upon the recent advances and future trends. And under each of the above sections, we'll try to cover some of the headings. Let's go to the epidemiology first. It's the 8th most common malignancy from the global perspective, and the 6th most common cause of cancer-related mortality. There are broadly two histologies that we will be discussing, the squamous cell carcinomas and the adenocarcinomas. Of course, there are a lot of other histologies as well, but the primary focus of this talk would be squamous and adenocarcinomas. If one sees the global trends, there is a wide variation. There is something called as the Asian belt, which has the highest incidence of esophageal cancers, and this seems across Iran, Turkey, and a part of north-central China. Interestingly, in these parts, I think squamous cell carcinomas is the predominant histology. India also falls in the same belt and sees a similar trend of the histology being common of squamous cell carcinomas. But world over, and especially in the West, what we see is that we see a marked increase in the incidence of adenocarcinomas, nearly so 400% increase in the past 25 years in the West. Here also in India, we do see majority of our cases of squamous cell carcinomas, although the incidence of adenocarcinomas are increasing by around 10%. And this was one of our residents, trainees with us, Shiv Shankar, who actually collated some of the data on the demographic trends, and we have published this series, and this is published in the South Asian Journal of Cancer. So anybody who really wants to have a look at the demographic trends in detail can have a look at this publication of ours. So very quickly going into the etiology of these cancers, as with most other upper aerodigestive tract cancers, alcohol and tobacco are the most common etiologies for carcinoma esophagus. Alcohol predominantly for squamous cell carcinomas and also tobacco for squamous cell carcinomas. But what is marked in yellow in the slides, tobacco to some extent, obesity and especially metabolic syndrome and high body mass index, leading to sometimes to GERD, Barrett's, and subsequently to adenocarcinoma. So these have been sort of the main etiology in terms of the adenocarcinoma histology. Of course, you do have a lot of hereditary aspects of this disease as well, tylosis, familial Barrett's, Fanconi's, and the flu and Bloom's syndrome. I think they constitute a minority, but predominantly, as with other aerodigestive tract cancers, I think it's a combination of either tobacco and alcohol for squamous and tobacco to an extent, and the other metabolic syndrome aspect for adenocarcinoma. So right from the epidemiology and the etiology, we do find some histology-specific differences that we are seeing in both the squamous and adenocarcinomas. And as we elaborate further, we can sort of study it in great more detail. Very interestingly, I think there have been studies, or rather hypotheses, I should say, that Helicobacter pylori infection is actually protective for esophageal adenocarcinomas. That was a hypothesis going on, and there was also a corollary to that, saying that if you eliminate or eradicate H. pylori by means of H. pylori eradication regimens, there could be a possible increase in Barrett's esophagus and esophageal adenocarcinomas. And this publication from the Swedish registry is one of the hot from the press, which says that there's no evidence to suggest such a trend is there. So there are lots of hypotheses about Barrett's and Barrett's esophagus, and I think it's very difficult for me to sort of cover all those aspects in this particular talk. Of course, we have a discussion section we can actually see and discuss about that as well. Very quickly, again, moving on to the evaluation, and this is the meat of the discussion. I discussed the epidemiology and etiology to put things under perspective. As with any other cancer, history and clinical examination is paramount. You do subsequently endoscopy and imaging. And what I have marked very important in this slide is the cardiac, pulmonary, and nutritional evaluation. And this is very, very important in the management of carcinoma esophagus. Cardiac pulmonary, basically from the point of view of establishing comorbidities and by and large establishing the performance status and the fitness of these patients, because the modality of treatment is actually dependent upon a lot of these things. Smoking cessation also is a part of the pulmonary rehabilitation or rehabilitation for some of these patients. And nutrition part is very, very essential, and especially since these tumors are in the upper aerodigestive tract or some amount of dysphagia, rather predominantly dysphagia, we do have a lot of malnourishment or malnutrition associated with this carcinoma, and it's very important to evaluate, screen, and actually correct the malnutrition prior to starting definitive treatment. When it comes to staging evaluation, staging investigations, again, this is a pretty much standard. The endoscopy, especially the upper endoscopy, GI endoscopies, CT scans, and more often, quite recently, we've been following a lot of PET CT scans more globally as well, and the endoscopic ultrasound. When it comes to white light endoscopy, I think it's very important. Initial evaluation tends to give the roadmap of the entire disease. We measure the disease from the level of the incisors, and to an extent, we see the proximal extent, the distal extent, the circumference, the distance from the gastroesophageal junction, so on and so forth. We take a biopsy to confirm the diagnosis. What is important in this perspective is if it is a metastatic adenocarcinoma or a metastatic esophageal carcinomas, be it adeno or squamous, there is a lot of future prospective development of doing MSI, MMR, and PD-L1, and this has just come about in almost every other solid cancer. Especially for adenocarcinomas, we do have the anti-HER2 therapy that has been approved both in the first line and the second line. So if there is a metastatic adenocarcinomas, or for that matter, any metastatic carcinoma of the esophagus, while doing the biopsy, it is worthwhile to keep mind on these markers and send it. Bronchoscopy is important, especially for tumors that are supracarcinal, and it's an integral part of the investigations. But what's actually sort of changed over the years is the incorporation of what is called as a high resolution endoscopy or image enhanced endoscopies over and above the white light endoscopies. And I think this is a talk in itself. There are various companies that have come forth with a lot of models, the narrowband imaging, the FICE technology. So you do have various technologies that do come up with high resolution endoscopies. And it's very important that these technologies are revolutionizing how we detect these cancers at an earlier stage. There are, in fact, a lot of NBI guidelines, and I would recommend a lot of the people who are in training to actually go through these guidelines. So the Asia Pacific Barrett's Consortium guidelines for Barrett's esophagus, and this is something that is very contemporary, and this is something that is advised to be followed. While doing an endoscopy, it's very essential to classify, especially if they're adenocarcinomas, what type of sieverts they are, and also the presence or absence of Barrett's, and try to stage the Barrett's by the criteria. And if you have a concomitant Barrett's, then to take a biopsy to know the extent of the lesion. Also, there are Japanese classification for the Esophageal Society of squamous cell carcinomas, which have been adopted of categories A1, B1 to B3. So these are definite NBI guidelines that are coming up, and I think it is revolutionizing our management approach in carcinoma of the esophagus. And the most important or the exciting thing is that endoscopy has not just diagnostic implications; it also has got therapeutic implications. And if you see any guideline, or the majority of the publications of carcinoma esophagus pertains to the early stage management of esophageal carcinomas, wherein therapeutic modalities like endoscopic mucosal resection and, more importantly, endoscopic submucosal resection is coming up in a big way. We do have at our center the endoscopic facility to do these procedures, and I will briefly in the next few slides come to this in much more detail. With regards to imaging, I think it's very important at this stage to recollect what is there in the T&M staging. The T is pertaining to the depth of invasion, or the deeper the tumor goes, the higher the T stage of the tumor, and the nodes is practically not based on the location, but based on the number of nodes. I think an understanding of the T and N from this perspective is really very important, because the use of an appropriate imaging is essential from this perspective. And of course, lymph nodes, for example, I think a lot of studies have come about with the study with the knowledge of lymph node ratio as a prognostic factor, and lymph nodes per se as a prognostic factor. Raveen, who trained with us in this study on lymph node ratio, we found that it was a very significant prognostic factor in the evaluation of carcinoma esophagus. So when it comes to evaluation by imaging, I think CT scan is the preliminary sort of investigation. But then there are limitations of CT scans that needs to be understood, that it may not be able to accurately differentiate between T1, T2, or T3 tumors. If the lesion is a T4 tumor, there is an obliteration between the planes, adjacent structures, then CT may be good enough. But then if the tumor is anywhere between T1 to T3, CT scan may not be good enough. That's the important limitation of CT scan evaluation. Of course, there are varying sensitivities and specificities for CT. And by and large, about 40% of the times in evaluation, we find that CT scans have been rather inaccurate in imaging. PET CT scans, I think these have come up in a very big way. And the implications of PET CT scans are not just in the upfront staging of the disease, but they also have some implications in treatment planning. They also have an implication in the restaging, especially with the popularity of neo-adjuvant protocols. And also, more importantly, they are very important from a prognostic perspective. And there have been a lot of studies, the Municon 1 and the Municon 2, which actually speak of CT scans as a prognostic indicator. So CT scans or PET CT scans have come up in a big way. And by employing PET CT scan in the diagnostics for staging of these tumors, various studies have said up to 30 to 40% of the time to be able to, it'll have an impact on the management of these tumors. So I think it's being increasingly used. We at our center, majority of the centers, not just in India and globally, are shifting to PET CT scan as one of the important evaluation if the initial CT scan shows a non-metastatic trend. Of course, there are concerns about PET CT scan. It's very good for distant metastasis. 20% of the times, esophagus being a very biologically very aggressive cancer. I think 20% of the times we do have some amount of distant metastasis, but it is grossly inaccurate for sort of knowing about the nodal metastasis in these patients. The nodal accuracy would be around anywhere only between about 27 to 90%. And that's why I think we come to the endoscopic ultrasound, I think, for better local regional staging of these tumors, and combined with FNAC and nodal staging is as accurate as 90% of the times. Endoscopic ultrasound is also coming up in a big way. And the reason is that there is an endoscopic eradication therapy. That is, in the endoscopic, I mentioned in the slide of endoscopy that when it comes to EMR and ESDs, and especially when you want to stage the disease, it's very important to know the staging of the disease, whether it's a T1A, B, or C, or there is a lot of treatment implications. And unless you do a mandatorily an endoscopic ultrasound, you will not be able to accurately stage this disease, and such candidates would not be hence candidates for endoscopic therapies. So endoscopic ultrasound and narrowband imaging are coming in an increasingly way in the management of early stage esophageal cancers. Of course, it has its fallacies. I think we can see and we can discuss this subsequently. So that much we have briefly looked into the epidemiology, the etiology, and how we are evaluating and comes to the meat. And this is where I would spend a lot of time because I think it's very important to understand a lot of things have gone in terms of the management, the philosophy of management, right from the 1970s, 80s to 2000s, and now has changed dramatically. And that's what makes the management of carcinoma esophagus very exciting. Prior to that, actually, like these are COVID times, and I think just a welcome break. I think we most of us, I believe, here are surgeons. This talk is, of course, is multimodality. Like, it talks about the broad philosophy, but then we have actually during the COVID times, it got some time to sort of well out the prioritizing for the cancer surgeries, and I thought, like, it would be worthwhile. I think anybody who has who wants to study about this. We're publishing in an editorial early last month, and so I think you can go through it and as to how do you plan your surgeries, especially esophageal surgeries, in the times of the COVID pandemic. From the management perspective, and this is a little personalized slides. I think you will possibly not find a lot of these evidence in many other guidelines, but this is what we tend or I tend to sort of see and go about. You tend to divide the patients basically into clinical groups. And early stage disease, and I'm specifically telling early stage disease because increasing use of the endoscopy, especially the narrowband imaging or the image enhanced endoscopies, we find that the pickup rate for these lesions are increasing. We've had the endoscopic ultrasound, and we've had the EMR and ESD technologies pretty recently, and we have found at least 7 to 10 cases in the last year and a half. So I think the problem was that, even in the publication that we did earlier, we found that only 3% of our esophageal cancers were in the early stage disease. And it's a common understanding, or it's a common perception rather, that we don't get early stage cancers. And my argument, or rather to say, is that possibly we are not looking for it. So a lot of these endoscopies have been done in patients who are follow-up endoscopies of upper aerodigestive tract cancers, and we have discovered about 7 to 10, in fact, a very robust medical gastroenterology group who have actually gone about picking up some of these lesions and doing therapeutic interventions for these. So that's the reason why the early stage is becoming very important. And by early stage, I would mean anything between T1A, TIS, and T1A. And locally advanced is the other stages, like, stages above T1B to stage 3. I would sort of place it in the category of locally advanced cancers. But of course, metastatic cancers, and quite a lot of our patients are actually metastatic. So I think it's a very important disease component, and I think we do precious little for these. But of course, there are some exciting therapies even in metastatic disease as well. And very importantly, I spoke in the slide of nutritional, pulmonary, and cardiac evaluation. We need to divide the patients into fit and unfit patients as well. Because some of the modalities, and especially the tri-modality treatment that we give for the carcinoma esophagus, especially the locally advanced stages, mandates that the patient should be fit enough to undergo the treatment. Otherwise, I think the treatment protocols completely change. And it's very important for us to categorize the patients in this perspective. Now, of course, for every disease, and not just for carcinoma esophagus, you have the patient's choice, whether he wants to undergo surgery or non-surgical treatments, and also very importantly, the physician experience. Traditionally, I think this was true when I was training as well. We had the surgery-only approaches for the management of locally advanced esophageal cancers, even locally advanced. Early, of course, even now, I think the standard of care would be surgery, upfront surgery. But even for locally advanced carcinomas, when we were training also, I think we sort of, had the surgically only approaches. And when I was training, and especially there were debates of trans-hiatal esophagectomy versus trans-thoracic esophagectomy, and there was two-field lymphadenectomy versus three-field lymphadenectomy. So all these debates were raging at this particular point of time when I was training. But subsequently, the philosophies have, of course, changed. And just for the trainees, I think it's very good to recap what an adequate lymphadenectomy is involving. Normally, you would do anywhere there is a transhiatal esophagectomy wherein there is absolutely no component of thoracic lymphadenectomy that is being done. There is the transthoracic approaches in which you have the two-field lymphadenectomy, which is here in the extreme left, and then in the middle there is an extended two-field, wherein you sort of address the left recurrent laryngeal nerve chain and the three-field lymphadenectomies. And it's very important to keep in mind the background of lymphadenectomies, especially in the era of post-neo-adjuvant therapies. We also had some early experience, and this was some of our data from the institute that we published. Shivaram was collected this data, and we published it. I think this was in 2013. Yeah, it was around a three-field esophagectomy experience, and we did show impressive survivals. Of course, it was 52% 5-year overall survival and complete transthoracic esophageal. But believe me, these are very highly selected group of patients. The fact remains that only 1/5 of the patients that actually reach our center, or for that matter, any center, you're able to offer any curative cancer-specific therapies. In the majority of the cases, we will not be able to sort of offer any curative cancer-specific therapies because of the fact of various reasons, either because of the sheer disease volume, as I said, plus the patient's fitness, for that matter. So, what this data from us shows that in a highly selected group of fit patients, if you do a proper upfront surgery, you could achieve survivals in the range of 37 to 50%. But by and large, what happens is when you see the entire cohort, and that's why it's very important whenever you read a study, you must see what's the denominator, whether it's a highly selected cohort or whether it's all comers that you've analyzed. When you analyze the outcome of surgery for the all comers, then what we find is that the surgery alone approaches fare very poorly in terms of long-term outcomes of 5-year outcomes, barely around, sometimes in single digits, sometimes barely in double digits, up to 15% or 20%. So when oncologists realize the futility of having the surgery alone approach in terms of poorer long-term survivals, they went into what is called the combined modality approach. That is, you add something more around the backbone of surgery. And what this combined modality approach means, incorporating of either chemotherapy or chemotherapy and radiation, and a lot of these studies have incorporated them prior to surgery. With regards to the neoadjuvant chemotherapy versus surgery.
Excuse me, sir.
Yes.
Sir, you're not audible very properly, sir.
Oh, okay, okay.
Yes.
Yeah, okay.
Thank you so much, sir. Sorry disturbing.
Yeah, sorry. Yeah, not at all. Thank you for reminding me. I think it's meant for you also. I guess it's important. Yeah, with regards to neoadjuvant chemotherapy and surgery, there have been a lot of trials, and there have been a lot of dichotomous results, in the sense like you've got some positive trials, you've got some negative trials, and of course there are various reasons for the positivity and negative trials. But by and large, if you find the data from the meta-analysis approach, what we find is the incorporation of neoadjuvant chemotherapy gives about 5% survival advantage. So barring these odd outlier negative trials, by and large, incorporation of neoadjuvant chemotherapy to surgery adds around 5% in terms of overall survival. And same is the case with neoadjuvant chemotherapy and radiation, where you have got a very plethora of various trials. I think it's very difficult for me to go through each and every trial of the cross results is something that I will go up in the next slide. But again, it showed a survival advantage of neoadjuvant chemotherapy plus radiation compared to the surgery alone arm. But there was no robust trial comparing neoadjuvant chemotherapy versus neoadjuvant chemoradiation therapy. So I think the audience or the people who are managing these tumors were by and large not getting a very clear-cut message. But what these trials definitely tell is that surgery alone is not sufficient. You need some form of neoadjuvant therapy, be it neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy. And what this approach does is definitely it increases pathological complete responses, more so in squamous cell carcinomas, and I will come to that in some time. And what we find is patients who achieve the pathological complete response do well in the long run. It has definitely decreased the local recurrences, and it has increased the overall survival of these patients. Again, I think this trial has actually revolutionized our practice. Despite the fact that this trial has got certain inherent flaws, I think when it comes to the discussion, we can discuss about it. But the overriding data that has come from this trial is that you've got a 25-month median overall survival advantage by incorporating neoadjuvant chemotherapy and radiation therapy prior to surgery. And such a survival at a very less toxicity of a regimen. So they used a regimen of paclitaxel and carboplatin with AUC2, and which was very much tolerable for these patients. And they got a 25% median overall survival benefit. Such an unprecedented benefit made it so attractive that world over people started, and even if you see modern treatment guidelines across the board for squamous and adenocarcinomas, they would say that neoadjuvant chemotherapy and radiation therapy is the standard of care. Despite the fact that one has to know that the comparative arm in the cross trial was surgery alone. It was not neoadjuvant chemotherapy. So such glaring were the survival advantages that world over people changed their practices to incorporate or follow neoadjuvant chemotherapy and radiation therapy as a standard of care for esophageal and junctional carcinomas. And this is, of course, the graph taken from that the updated cross results. And I think very clearly you can see the Kaplan-Meier graphs. The responses are very good for squamous cell carcinomas. In fact, if you see, the survival is up to 83 months for squamous cell carcinomas, vis-a-vis 43 months for adenocarcinomas. So clearly, I think we talked about histology differences when it comes to the etiology and also when it comes to the epidemiology of these cancers. And clearly, in terms of responses to treatment, we see that squamous cell carcinomas preferentially rather, respond well to neoadjuvant chemotherapy and radiation, whereas adenocarcinomas don't tend to respond much. Yet, what we have found is that despite that, you have almost a 13% gain in survival in case of adenocarcinomas when you incorporate chemotherapy. And I think this is something that we know. So what this trial emphatically says is that neoadjuvant chemotherapy and radiation works both for squamous cell carcinomas and adenocarcinomas. The magnitude of benefit is much, much higher for squamous cell carcinomas than in adenocarcinomas. Of course, since the comparator arm was only surgery, there was no head-to-head comparison with neoadjuvant chemotherapy. There were about 5 other meta-analyses that were there. What it said is that the PCR rates, as I said, was much higher in terms of neoadjuvant chemotherapy and radiation therapy, 22% versus about 4% odd. R0 was better, and 3-year survival was also 10% better. So, but again, so impressive are the trial data. Now, again, as I said, it all boils down to whether you can administer these therapy, especially this tri-modality treatment, knowing well that it is working so elegantly and so beautifully in our And this is our own experience. I think we published this data a couple of years back. We have been using the neoadjuvant chemotherapy and radiation protocol ever since late 2013, I think, and we've had quite an experience about this. This was the publication of our first 50 patients in our trial, and I'm sure a lot of other centers in the country, or very few centers actually, a lot of centers actually don't practice neoadjuvant chemotherapy and radiation. A majority of them give neoadjuvant chemotherapy and reserve neoadjuvant chemotherapy and radiation. But there are at least quite a handful of centers in India which have published in this, similar to our experience. And what our experience actually tells is that the median age of our cohort was around 50 years, and this is about a decade younger than the Western cohort, a male predominant. And as said, 90% of them are squamous cell carcinomas, barely about less than 9% adenocarcinomas. 69% of our patients were lower third lesions. And when it came to the actual administration of the protocol, we found that almost every patient actually completed the protocol in terms of radiation perspective. but 20% of them had some sort of a treatment delay, but that was gap corrected. Again, close to about 70 to 80% of the patients could complete all the 5 cycles of chemotherapy, that is paclitaxel and carboplatin. And that goes on to say, and a couple of them had to miss their 5th cycle and so on and so forth. And most importantly, there was no treatment-related deaths in these series. And the very significant aspect of our finding was the results. There is about 38%, and I think had pathologically complete responses. So about more than a third of patients have got a pathological complete responses. There was no post-operative mortality. So I think the concerns are fairly sort of laid to rest, that if you select your patients properly, and I think that's the most important crux of the selection of these patients, you are able to administer the trimodality treatment without much problem. And of course, I think from the surgical perspective, I think everybody has their own technique of anastomosis. I've also learned the hands-on anastomosis. Even now, I'm comfortable actually when doing a hands-on anastomosis. But then what we have found is there are certain distinct advantages of using a stapler technique. And actually, we have published one of our stapler techniques, which uses just 2 linear staplers. I think this has been published early last year. It's a very elegant technique, and what we have found is we almost have practically 0 strictures. There may be some odd leaks because that's to do with the inherent nature of the tissues that we are anastomosing, but the leaks are also far less, and strictures are practically eliminated with this double staple technique. So I think this is also available in the Medline. I think anybody who's interested can actually go about and read this. And very finally, I think I'll need to go into some of the recent advances and the future trends. And I think because any talk, we have to give some flavor of future trends. I think it's very important from that perspective. And of course, as I said, EMR and ESDs are very important. Endoscopic resection, many centers are doing this. You really require a very good selection criteria. These are the selection criteria, less than 2 centimeters. But as I said, we just do have a handful of tumors. And there's also an artificial-based aided selection criteria for these tumors. So it's not just that all patients are candidates for this. Very, very highly selected T1A tumors are for this. And sometimes when it's a high-risk T1B, as seen in the endoscopic ultrasound, you can go ahead with these. But when there is very extensive carcinoma in situ component, when there is a high grade dysplasia with nodularity and ulcerations, then actually I think in a traditional esophagectomy is much better. I must add that although ESDs and EMRs are coming up in a big way, various societies are endorsing the practice. The levels of evidence when compared to traditional surgery have not been that robust. So I think it's an exciting technology, no doubt. Since you are avoiding a surgical modality, but then you must be really very, very choosy about your patients. And of course, it requires a lot of skill sets. There are, of course, a lot of few centers in the country which are doing this. And there have been issues with ESDs and ESRs, sometimes strictures. I think these are very important, but there are some technical issues which we can discuss subsequently. And of course, this is an important part of the thing when there is a major value add for if at all there is a minimally invasive surgery advantage. And I feel that in thoracic cancers, it is distinctly advantageous. In gynecological cancers, we are seeing, at least from the oncology perspective, the evidence seems to be dwindling, at least in terms of cervical cancers and ovarian cancers. Of course, it was never there. But in cases of thoracic malignancies, I think the evidence is of course, at least whatever the evidences are there, it says that it's equivalent in terms of both in terms of short term as well as long term, the laparoscopic approaches, robotic approaches, and I must say that there are a bit of people who use the hybrid approach, because it involves 2 components. Either they use the thoracic component by minimally invasive means, or they use the abdominal component by minimally invasive means. So I think people should, where they are evaluating technologies, must know that a lot of hybrid approaches are also pretty much popular. Of course, there is good randomized controlled data comparing open esophagectomy with minimally invasive esophagectomy. Youngsters can read 2 of these very landmark trials, the TIME trial and the NERO trial. I think going on to state that not just the short-term outcomes, but there are trends to say that the long-term outcomes also may be slightly better off with the incorporation of minimally invasive technologies. And RAMI, that is the robotic, I think it's catching up in a big way. I think a lot of trials are saying that it is much better in terms of long-term outcomes. And this was a very recent data from the Korean group. What's exciting is I think I had visited China, and this was not now, thankfully. It was about a couple of years back, and I saw them do what is called as the Markey technique, that is called the mediastinoscopy assisted transhiatal esophagectomy, and they sort of do this to avoid the pulmonary complications. In a majority of the minimally invasive approach, the benefit is more in terms of pulmonary complications. So, youngsters, if you're reading papers of the time and the mirror trials, the primary endpoint of those trials are pulmonary complications or the 30-day Clavin-Dindot scores. And I think this technology of the mediastinoscopy associated transhiatal esophagectomy is something, it seems a little sort of a different sort of an approach, wherein you sort of approach the patient from the cervical approach. That is, you do the incision for a tracheostomy, introduce a mediastinoscope, and do a transhiatal esophagectomy. But I've seen this. I think it is sort of pretty different, I must say. But there are a couple of groups which have actually sort of published their long-term data, and this is something that is evolving. I must say it's not as such standard of care, but this is one another way in which you can use your minimally invasive technologies, either your mediastinoscopy or your robotics. And I just mentioned also that even in our data we do have about a 40% PCR rates, and very many studies have actually said in carefully selected patients, I think about 30 to 40% or possibly more can achieve a pathological complete response. That goes on to the sort of hypothesis saying that whether we can avoid surgery altogether in a particular cohort of patients. And this was also seen in a lot of rectal cancer data. I think there were trials that said that avoiding a surgical approach, and this has also been tried or sort of explored in esophagus cancer patients also. I think the patients who have a complete clinical response post neo-adjuvant chemotherapy and radiation, and they have a strict protocol. You do PET CT scans, you do double catch endoscopies and biopsies for these patients. You use the EUS, you sample your FNA, sample your nodes, and very stringently, if you follow up these criteria, I think they are saying that in a certain cohort of patients, you may be able to avoid some surgery. But again, I must say that I'm discussing these things only in the section of recent advances and not the traditional standard approach. And there is something called as a conversion surgery. So that is for unresectable carcinoma of the esophagus, the standard of care is chemotherapy and radiation, the direct CTRT. But then a definitive approach. But then some centers are chemo-selecting these patients with chemotherapy and trying to do it. So this is some sort of an interesting ongoing approach that has been happening. And of course, there is a lot of buzz about immunotherapy, not just in this cancer, but in very, very many cancers, especially in metastatic cancers. I think what one can do is to stent these patients to, if whenever necessary, if they have any obstructive symptoms, do a lot of various things to sort of get their functions getting better. And subsequently, there is this immune checkpoint inhibitors and chemotherapy approaches are there, which are quite promising, and their outcomes are better than chemotherapy. And what my final take would be like, yes, of course, esophagus is a very biologically aggressive cancer. What I've done during this talk is I've not tried to be very comprehensive. I've just tried to give a broad overview. I know that there are a lot of points that have sort of, there is a scope for a lot of discussion about the further points. But I've deliberately left certain things open so that I think a lot of us can sort of take up a discussion. And I must say at the end of the day that the results of the neoadjuvant therapy seems to be very exciting, very promising, but they have to be taken with caution because not all patients are fit enough to undergo this trimodality treatment. Sometimes you may have to tweak your protocols based on the fitness, and that's logical for every cancer, and more so for a biologically aggressive cancer like esophageal cancer. And case selection, I think, will continue to play a very key role. I think I would end my talk, and I think I thought I would end it a little earlier so that I think in case there are any further questions, comments, or discussion, I think we can see and take it up. And I would like to thank Dr. Patta Krishna for the opportunity I think it's been. I think he's a star in the social media. We have to take a lot of lessons from him as to how to go about. And whatever you're doing, sir, in the period of the lockdown is simply we really appreciate it. And with that, I think I would end my talk. And thank you once again for the opportunity given.
Thanks, Arvind. Thanks for those nice words. And it's a wonderful and comprehensive lecture, I should say. Very clear, and and again, it's a sort of overview, as you rightly said. There are so many areas which are debatable. I'll throw open the floor, and I'll start with Ankit. Ankit, what is your question?
Sir,
Sorry, yeah.
once after endoscopy and biopsy, we diagnosed CA esophagus. So, as per the guideline, now up to now, it is recommended as CT chest with abdomen. So, should I go directly for PET CT, or still I follow CT chest with abdomen?
Yeah, I think that's a very important question, and I think it all depends on which setting you are doing it. It will be difficult for me to sort of advise a PET CT for everybody, especially who are practicing in a community. If you see a majority of the guidelines, they say CT would be an initial evaluation. But definitely, I have in my talk told you that there are limitations about the CT scan. That is, you cannot differentiate between T1 to T3 tumors, and sometimes distant metastasis up to 30 to 40% would be missed. A majority of the centers, and as a part of a protocol, tend to prefer PET CT as an initial imaging modality. So if you're practicing in a non-community center where you have the facilities for a PET CT, I would say go for a PET CT because of these reasons. It can sort of upstage the disease and also change the management up to 30 to 40% of patients. But I think the guidelines broadly say that they don't mandatorily recommend, but it is preferable. That's what I would sort of say to a PET CT scan. But with the CT scan, you get reasonable information.
Ajay Reddy, what is the question?
Good evening, sir.
Yeah, good evening, Ajay.
Yeah. So my question is regarding the neo-adjuvant therapy that you spoke about. So at our center in Tata, we still follow NACT versus as opposed to NACT-RT. The explanation we are told and we have been taught is because most of the cohort of our patients are usually coming from outside places, are nutritionally debilitated. They don't have a social support, and NACT-RT is technically a little more challenging to give. And despite the cross results, we've still stuck to NACT. So what about at your center? So I know it's a referral center, and you have all sorts of patients coming in, and still NACT-RT is technically more challenging to give. So
I entirely agree with your viewpoints. I think we must base our decisions based on the resources that are available. I just presented to you the evidence.
Yes.
In case of squamous cell carcinomas, there is no doubt neoadjuvant chemotherapy and radiation therapy seems to get the upper hand in terms of responses, pathological complete responses as well. But in terms of adenocarcinomas, there is a lot of flexibility. You can sort of use neoadjuvant chemotherapy approach for adenocarcinomas. Having said that, I think there is a need for a proper randomized controlled trial between neoadjuvant chemotherapy and radiation. I think the lack of it sorts of makes practices very heterogeneous across centers. And with regards to our center, I think we try to sort of fit in most of our fit patients into the neoadjuvant chemotherapy and radiation protocol, even the adenocarcinomas as well, the lower third adenocarcinomas as well. But of course, I know in Tatas I've trained there, and I know the numbers are pretty huge, and it is difficult. I think neoadjuvant chemotherapy and radiation protocols demand that the patient should be around for that period of time. So I think all those constraints are there, and I think each of the center can sort of make adjustments. But as far as I can say, for adenocarcinomas, you're easily good to sort of give the neoadjuvant chemo approach. Squamous cell carcinomas, of course, it's sort of the evidence is sort of tilted towards neoadjuvant chemotherapy and radiation.
Okay. So my second question is regarding your technique. So I suppose most patients go in for a transthoracic esophagectomy. So, but what is your rule of thumb for selecting someone for a transhiatal esophagectomy?
No, if you see the cross data as well, I think they had given a choice for the surgeons with regards to the therapy. In fact, a lot of patients in that study also underwent hiatal esophagectomy itself. But the patients who have undergone transhiatal esophagectomy in our series are a lot of them who have got adenocarcinomas of the lower third of esophagus, and sometimes or almost all of them are adenocarcinomas of the lower third of the esophagus. When there are squamous cell carcinomas, I think there has to be a tendency to do some sort of a transthoracic approach because the need for lymphadenectomy is important. Of course, there are some studies to say even if your adenocarcinomas is in your lower third and possibly if your length of your adenocarcinomas are say more than 3 or 4 centimeters, some of the centers will actually opt for a thoracic approach for these patients. So, but having said that, I think what has happened is that the goalpost has changed with the incorporation of neo-adjuvant therapies. We don't really know which is the exact thing, like whether to use transhiatal or in transthoracic, what lymphadenectomy to be used. I think there are certain open questions. I think, as I said, you should dictate it by your histology, your location of the tumor, and the performance status of the patients. And transhiatal esophagectomy could be an acceptable option, especially for patients who are borderline compromised, who are adenocarcinomas, especially of the lower third esophagus.
Thank you so much.
Yeah, the next question.
Excuse me, sir.
Yeah,
how do you manage multicentric esophageal cancer? One tumor is into cervical esophagus and second one is another part of the esophagus.
Yeah, I think multicentric tumors are a challenge basically. And one thing, of course, that was not covered is that in my slide was any tumor, majority of the times the tumors that we take up for the surgical protocols are the tumors that are more than 5 centimeters from the cricopharynx. So if you have a tumor that is higher up, say within 5 centimeters of the cricopharynx, then you can consider definitive chemotherapy and radiation therapy in these patients. But having said that, I think such tumors have a very poor prognosis, especially the ones that are very long and also some of them which are multicentric. And of course, you can personalize your treatment based on other factors. It's just not one factor of multicentricity. But by and large, when you said cervical, then I think the option becomes more and more clearer. So in a real-time scenario, when you're faced with particular issues, I think what really happens is that you have to study the issues in totality. And more often than not, when you do that, you tend to get your answer there.
Second question is here, if adenocarcinoma, if proximal edge of the tumor is within 5 centimeter of cricopharynx, how do you manage these cancers?
So generally, adenocarcinomas do not occur there. It is the squamous cell carcinomas almost always tend to occur in the upper third and the middle third. The adenocarcinomas occur only majority of the time in the G junction in the lower third of the esophagus. Very rarely you would get any adenocarcinomas. If you are having some sort of an adenocarcinoma in that height, then you must suspect some metastatic disease.
And sir, if it is squamous and within 5 centimeter of cervical esophagus, then?
You're trying to put me in a spot, but then I think if you see the data, I think in the cross results also, if you see only 50 patients rather were in the middle third tumors, and very less of them were tumors that were going slightly higher up. So I think here you can use your individual judgment. I think if you're able to safely get a margin higher up, then you can possibly incorporate a trimodality treatment in these patients. But if you feel that your proximal extent, you may have to sort of are going into your cervical esophagus very clearly. In that case, then your margin is suspect, then you would possibly not do. And the stapled approach, what I had shown, is exclusively reserved only for tumors in the middle third and the lower third. If the tumor is there in the high mid third or the upper third, you will not be able to put a stapler. So in that case, it will be a very, very difficult hand-sewn anastomosis. It will be a technical nightmare for the surgeon who is doing that. But what I would, in short, say that the data from the middle third can be extrapolated to such tumors.
So,
Rakesh, Basant, it's your turn now.
Yes, sir. Sir, my question is about patients who have a T2N0 tumor, sir. What is the view regarding such group patient? Do you refer upfront surgery or give them neo-adjuvant chemoradiation, sir?
I think it's a borderline question in a way, but I'll tell you, to diagnose T2N0 itself is very important. That means you will have to do an imaging, including an endoscopic ultrasound. Only then you will confidently be able to tell it's a T2N0. And both the options are there. If you see the NCCN guidelines, I think they would sort of say that upfront surgery is also an option, and a majority of the centers would do upfront surgery. But then there are certain guidelines that say anything above T1B you can consider neo-adjuvant option as well. So again, I think this falls under the sort of the gray area of sorts. You definitely need to stage these patients with a PET CT and endoscopic ultrasound better. And if you feel that the patients are okay for surgery, I think you're good to go. And either ways also, if you're following any of the neo-adjuvant approaches, also surgery would be an integral component to these patients. But having said that, these are a eminently curable subset of patients, so you should go very aggressive on these patients.
Okay, thank you, sir.
Yeah, Dr. Mrunal. What is your question, Dr. Mrunal? Dr. Karthik?
Good evening, sir. Karthik here.
Yeah, hi, Karthik.
Yeah, sir. After cross for esophagus, we reassess around 8 weeks and take them off for surgery.
Yeah.
As evidence is emerging in rectum that after short course RT you wait for longer, there is a better effect. Is there any data that 8 weeks is the ideal time, or you can wait still further, which would make your oncological outcome? And what is the surgical planes? How difficult it will be the more we wait?
Yeah, I think it's in rectum. I think the data is very sort of it's tending that the longer you wait, you may actually sort of do better. But in esophagus, I think the sort of results are a little mixed. What I can definitely say is that you should not ideally perform a PET CT within 4 weeks of your completion for response evaluation, and this is exceedingly important. A lot of us tend to sort of rush to do the PET CT. So if you're doing a PET CT, do it after around 5 weeks, and anywhere between that time you should be good to go and take these patients for surgery. I think by and large, I think majority of the centers in the world, they would sort of operate within about say between the 5th and 6th week or 7th week or so. And I think this is also to go. I think if I were to go a step further, it also depends on sometimes how the response of the tissues are there. The effect of radiation therapy on the tissue is also very important. Certain patients, so I think there is a separate branch which actually goes into how the tissues inherently respond to radiation therapy. So I think, of course, that is for a research perspective. But the longer you wait, at times I think there is a risk, especially in their middle third tumors, your plane would be a little challenge. So by and large, if I were to answer your question in a very short way, I think do a PET CT. Appropriate time would be around 5 weeks, and then immediately take the patient up for surgery.
And second question, sir, if the reassessment PET shows complete response, still we will be going ahead with surgery, sir?
Yeah. I think that is the practice that we are following, and the majority of centers are following across the world. But this is, and again, as I said, that especially in squamous cell carcinomas, where the pathological complete response rates are in the range of around 40%, people are sort of thinking that, are we overdoing surgery for a certain subset of patients, similar to the Haber-Gamma series in rectal cancers? So a certain cohort of patients, and these are the patients, as I said, complete clinical response, both by endoscopic and a PET CT and by EUS and also guided FNAC, they are currently being randomized into a trial of observation and intervention, or surgery or salvage esophagectomy when the tumor recurs versus immediate esophagectomy. I think until the results of the trial come, all our patients are going to be subject to esophagectomy, because we would not know which of the patients is the complete pathological responder and who is not. Because even in RCDs, we did find some microscopic residue even in the nodes in some of these patients. So you do get a lot of differential responses, and some of the TRG grades are surprising. So unless you do surgery, you would never get to know who are the complete pathological responders. The short answer is almost all patients tend to get it. Only in a trial setting you want to do it, I think you can sort of enroll, and with a very, very strict selection criteria for these patients.
Thank you, sir.
Dr. Yashashvi?
Hello. So my question was, if the patient presents with absolute dysphagia and borderline operability, T3 or borderline operable T4, do we go ahead with chemotherapy or chemoradiation, or we plan for surgery like we do in stomach?
There are two things. You said it is borderline, so operability or T3 and above. So I think the choice is that upfront surgery is sort of ruled out, because I think as was said that in a majority of these locally advanced, you try to give some neo-adjuvant therapy. Having said that, I think the priority is to correct the nutrition. I'm sure that this patient is going to be nutritionally challenged, so it's very important for you to sort of either you sort of dilate the patient, that is dilate the tumor and place any enteral feeding tubes, or do a feeding jejunostomy for some of these patients, or very rarely, if you find some of these series, they would put a plastic stent for these patients and retrievable stent for these patients. It's very important that you correct the that is relieve the obstruction, correct the nutrition, and it has to happen simultaneously, and then you start whatever your treatment is based on the stage for these patients. Either you give neo-adjuvant chemo, possibly because of the fact that he's slightly malnourished.
Right. Thank you, sir.
Dr. Mrunar?
Yeah, so this is regarding the gastroesophageal junction tumor. What will be, how do you decide the CVOT 1 and 2 and CVOT 3, the surgical approach, and something about the margin, irrespective of the GEJ junction tumor?
Yeah, I think this is something also although Sieverts described it much earlier, I think this still is some sort of a confusion as to how to go about. Even there are some changes in the TNM7 and the TNM8 also. So this is one aspect that keeps changing always. So what is there is that the Sieverts 3, they treated as a stomach cancer essentially. So you would sort of that is more than say 2 centimeters away from the sort of so you treat it as a stomach cancer. And again, it also depends on what is the stage of these patients. If it's an early stage, if it's a late stage, and all those things. So your treatment modality practically sorts of is determined by also the stage of these patients. And there are some studies to say I must say that Sieverts 1 and Sieverts 2 to a large extent is they try to treat it as an esophageal cancer. And by and large, your treatment modality is same as what stage you do. Having said that, I think these are the subset of patients in our population where we have done a lot of transhiatal esophagectomies in post neo-adjuvant chemotherapy and radiation. It is very difficult to sort of because what happens is these proximal GE junction cancers, proximal gastric cancer or GE junction cancers, they tend to be very aggressive. So it's very difficult for you actually to get a very sort of an early stage cancer in these patients. So you may get, but I'm not telling you may not, but there are two, three ways of approaching these cancers. And it is a preference. Some of them do a left thoraco-abdominal approach and get the margins for these patients. They go up to the inferior pulmonary vein and then do it in an abdominal route. Some use a transhiatal route and some use a thoraco-abdominal route. I think the options are multiple in Gero, and you'll have to sort of choose one which you are good, which your center practices.
So about the margin, please.
No, as I said, you tend to if it's an adenocarcinomas, you tend to go up to sort of the proximal margin has to be at least around 5 centimeters. So you go up to the level of the inferior pulmonary vein and get the margin essentially. These patients.
Dr. Madhumurali is speaking on G junction tumors at 8 p.m. tomorrow. Please attend.
Yeah, thank you, sir.
Thank you, great. I think so that will make things a little easier. Yeah.
Thank you, sir.
Dr. Revan.
Sir, when do we do cervical lymph node dissection in a case of CA esophagus? Hello, sir.
Oh, it's a good question. I'm there. The thing is that this is coming to lymphadenectomy. Whether you do a three-field lymphadenectomy. 1 second, I think I think my internet was a little unstable at that time. No, so this is where you do a 3-field lymphadenectomy, and Generally what happens is, if you have lymph nodes, obvious lymph nodes which are there in the 106, that is in the 104, 106, or in these regions, in the paratracheal regions, a priori, or cervical, if you have cervical nodes upfront, then you do these patients. Then you do these three field surgeries. But as I said, like if it's a middle third tumor with nodes which are there higher up, then in some of these patients you may have to do a three field lymphadenectomy, despite the fact that you've done neo-adjuvant chemotherapy and radiation. So as I said, it is all dictated by what is the finding in your pre-SPECT CT scan or CT scan evaluation for these patients. If you have disease there, macroscopically, obviously, I think logically you'll have to clear that disease. If the disease was there a priori, and if the disease has shrunk also, it's logical that you actually go about and clear. If the tumor is far away from there, you may choose not to do those surgeries, and you may do a two-field lymphadenectomy or even a transhiatal lymphadenectomy.
So if after NACTRT or after the neo-adjuvant, if the nodes disappear, even that, then we should go for a cervical lymph node dissection, sir.
Yeah, especially if it's a middle third bulky tumor. If your preoperative PET CT has shown some disease there, it may be worthwhile to sort of clear those diseases. But having said that, I think these are just broad guidelines. Sure. What actual surgery you will have to follow is actually dictated by what you are observing. And with the use of minimally invasive esophagectomy, I think the decisions are being far more easier. You're able to. The problem was when we were doing the open surgeries, these structures were very difficult to visualize. But when you're doing minimally invasive esophagectomy, I think it is slightly more easier and accessible to clear these areas. So I think and again, I think just because you're seeing it, you should not clear it. The guideline is that that if there is a bulky tumor, especially in the middle third, or if there have been macroscopic disease a priori, then you go and clear it.
So my second question is, sir.
Revant, you have to give chances to others, please. Your time is up. Dr. Srijan?
Yeah, good evening, sir. Sir, this is regarding one of the important points you said about the patient choice. So, supposing at upfront we have a squamous cell carcinoma, esophagus, middle or lower third, and we are giving the options to the patient about a multimodal treatment, which is NACRT followed by surgery. And the patient either does not wish to undergo a morbid surgery or wishes to have only a single modality, and we send the patient for definitive chemoradiation only with a higher dose. So at that point, what is the amount of benefit or the difference between the two treatment modalities of a chemoradiation followed by surgery versus a definitive chemo-RT that we should be counseling to the patient?
No, I think patient's choice is very important determinant in this issue. And as you rightly said, if the patient is not willing for a trimodality, a definitive CTRT can be done. And especially if it's a squamous cell cancer, I think as I said, the chances of response are very good, in the range of around, as I said, around 30 to 40%. Having said that, these patients you must tell these patients that if they achieve a pathological complete response, which will happen in about 30% or 40%, then their chances of survival will be pretty good. But you must not commit to them. And even when you're giving a definitive chemo-RT, the doses of radiation therapy is very, very important. A lot of radiation oncologists I observe now, they tend to go up to 60 gray. And there is no role of giving 60 gray in such cancers. The maximum dose of radiation therapy on a definitive intent is 50.4 gray. The studies have shown that you don't achieve any incremental response benefit by giving your dose higher than 50.4 gray. So that's the importance of this multimodality approach. You must talk to your radiation oncologist and make sure that they are not over treating, or in the sense give extra dose of radiation for that. And even you'll be good at that. So I think, as I said, it all depends on and because of the impressive responses of squamous cell carcinomas to your neo-adjuvant chemotherapy and radiation therapy, there are currently trials being explored for no surgery in the complete clinical responders. So definitely a subset of patients who achieve pathological complete response, they are going to do very well.
But literature-wise, we are safe to say today that if you go the multimodality treatment, your chances of a survival are better.
Yes, definitely. I think even your definitive CTRT is also a multimodality approach. I must tell you that in the tri-modality approach, though it seems very impressive, very few patients are actually. Of course, it all depends on which center you're practicing. If you're practicing in a sort of a community sort of a center or a regional cancer center, you get patients in various forms. Like a lot of them malnourished. Also, you'll have to. So selection becomes a very important criteria. And even in our center, we are able to offer it only for a few selected patients. A lot of the patients who sort of, by default may go in for the definitive chemo radiation therapy. And I must tell you that this is not an inferior option for some of these patients, because in between, if you see, till the cross results came, a lot of centers world over were practicing definitive chemo radiation therapy also. So I think and even if you see in the NCCN guidelines, it is one of the modalities of treatment, one of the accepted modalities of treatment, although the tri-modality would be preferable.
Thank you, sir.
Harshvardhan? Harshvardhan, what is your question?
Hello, sir. Good evening, sir. Sir, after esophagectomy, what is your follow-up protocol, sir? When you will repeat CT?
Yeah, I think that's very important. Generally, at least if you see in the what we tend to do is that if you're giving a tri-modality treatment for these patients, and I'm being a little practical in this, I can actually answer this question in many ways, but after. So what is important and what the guideline also tells us, if you're able to sort of, do anything worthwhile for these patients, then you sort of, do a rigorous follow-up. Having said that, I think they say for endoscopies and CT scans once in 6 months, I think that would be a reasonable regimen to follow. But I must tell you what is more important for these patients is how you sort of maintain their nutrition, how you maintain the sort of their quality of life. And that is going to be very, very important for these patients. So I think the focus for rehabilitation, especially a lot of these patients post esophagectomy will have some sort of dysphagia. So you must advise them about the dietary counseling, about the sleeping, taking small frequent meals, sleeping posture, and all those things. All those things are very, very much important. And with regards to imaging and endoscopies, I think I told you, I think once in 6 months should be a reasonable way to go. At least for imaging, endoscopies you can repeat as and when they have some issues.
Dr. Srinivas? Dr. Srinivas, what's the question? Dr. Srinivas Agrawal?
Hello, sir. Hello.
Yes,
sir. My question is, sir, patient with a middle third esophageal tumor, if having left supraclavicular or right supraclavicular lymph node, would we consider a regional node or a M1 disease? What about distal tumor with a left supraclavicular or right supraclavicular node?
Yeah, I think it's a very important question. As I said, the end staging of carcinoma esophagus is not based on the location of the nodes per se. It is based on the number of nodes. Having said that, there are even your supraclavicular and your celiac is also considered a sort of a regional sort of a lymph nodal basin. Anything which is beyond the confines of the supraclavicular and celiac will be taken as a non-regional node, which is a metastatic node. But your middle third cancer with a supraclavicular node will be taken as a loco-regional disease and will be treated accordingly. And but your lower third tumor with a supraclavicular node, although it is a loco-regional disease, it is a relative contraindication for surgery, purely considering the biology of the disease, essentially. Having said that, if you see earlier studies of esophagus and the lymph node mapping that was done, even in lower third cancers, microscopically, you would find about 30% of them could still be positive. So if you have, so the difference is that if you have macroscopic disease, be a little sort of careful of a lower third with a macroscopic disease. But having said that, both the scenarios, what you said is a loco-regional disease, and you tend to make your treatment or a potentially your intent of treatment is potentially curative in these cases. Although you tend to know that some of the lesions, and especially the lower third with a supraclavicular node, may tend to do poorly.
Any more questions from the audience? There are a couple of questions in the chat box, but I think we have taxed you enough, Dr. Arvind. Thank you so much for a great lecture and wonderful discussion. And we'd like to have you soon sometime next week. Thank you so much.
Definitely, for your time. Sir. Thank you for the opportunity, and I enjoyed the interaction.
Yeah. We enjoyed your talk too. Thank you. Thanks.
Thank you, sir. Thank you.
Thanks, everyone.